Oh, you just took my introductory comments. Thank you. She just wants to see, can I survive without my notes? I hope that's a lot of information. Do we have any questions from the audience before we move forward? Any concerns or questions? So again, feel free to approach us. We're here to help you. We're here to help facilitate that networking and discussions. Today, we have a very special keynote speaker who I would like to consider both a friend and a colleague, Dr. Victor Montori. Dr. Montori is a physician at the Mayo Clinic. If you've ever heard him speak, you'll know why I'm so excited to have him here with you today. He is very energetic, he's very passionate, and he really has been doing fundamental work in patient engagement and understanding the patient's perspective in the delivery of healthcare. He serves as the director, he's a researcher, with an appointment at Mayo's Knowledge and Evaluation Research Unit, in addition to providing clinical services at the Mayo Clinic. And as a researcher, he focuses on evidence-based clinical practice, shared decision-making, minimally disruptive medicine, which you're going to hear a lot about today, and systematic reviews and meta-analysis of the literature. Victor's interested in how knowledge is produced, disseminated, and taken up in practice, leading to optimal healthcare, delivery, and patient outcomes. So without further ado, Dr. Montori.
Thank you very much, Lucy. Yeah, I'm on. Thanks. And are you going to dim these lights so you can see the slides better? Okay. I'll be moving around because this is a wide room, and if I focus on these guys over here, then those guys over there are going to get really upset. And I don't like violence. Even though it seems like the thing to do. At the bottom is my email address. It's the equivalent of electronic suicide, right? I mean, I'm putting my email address, inviting you to email me. But I do respond to emails, so if there are any questions or issues that were to come up in our discussion that you would like to follow up with, by all means, send me a note. And then for those who are tweeting live, that's my Twitter handle, so you can use that as well as part of your sharing or not here. I work at the Care Unit, which is that thing on the top left. It's a research group focused on understanding what's in terms of our patients, what's best for them and their families. That's our core activity, and it's part of the Mayo Clinic. And I've worked with Lucy, and our team has worked with Lucy and her team for a number of years, but this is my first time here, and I'm delighted to be here. That's not true, actually. I just lied to you. I've been here before, but not in this capacity. It was 1995, and I was looking for a place to train, and I don't think we clicked. So here's Maria Luisa. Maria Luisa, she's originally from Peru. That's where I am from as well. And she lives in Alaska with her son, Peruvian guy. Her son has two daughters, and they live with her. She doesn't speak very good English. She's fairly isolated. Now, I want you to just look at her. Just spend a few minutes silently looking at her. Look at her surroundings. Look at her wrist, at her tabletop. Look at her eyes. What do you see? What do you see? Just yell it out. What do you see? Too many pills. What else do you see? Sorry? Overwhelmed, yes. What else do you see? Yes. Yeah. Interesting, isn't it? And obviously this is a patient with adequate access to healthcare and a lot of healthcare, and yet you're describing somebody who's not well. She has multiple chronic conditions. She actually is on dialysis 3 times a week. She lives, I told you, with her son and family, does not speak English. Her diet is really bland, right? When you're on dialysis, you have multiple chronic conditions. The only thing really you can eat safely is cardboard. And her main contact with the outside world that speaks Spanish is by phone, calling family in Peru and speaking to them in Spanish. It's very isolated. And so the key thing for this patient when she comes to us is to answer this question: what's best for me? What's best for my family? And we hope that the answer will be our care. The care that we can give her will be what will answer that question of what's best for her. And that's the key thing, is how confident are we that for patients like Maria Luisa, our care is the answer to the question, what's best for me and my family? So this is what the journey we're going to go through this morning. I have no disclosures to make. Our research group, when we started about 11 years ago, we made a commitment never to take money from any for-profit organization given the kinds of things that we do in our research. And it's been really hard, but we've been able to keep up with that promise. To understand where do people like Maria Luisa come from, we must understand how we are building and assembling our societies. What kind of world are we in? So when we look at a world, we can look at it this way. We can see that at the most innermost of us, we come from a world that is made up of our age, our sex, our genes, that we have some certain lifestyle choices that we've made, maybe our families made for us to begin with. We live in a particular community surrounded by a particular society which lives and breathes certain values and certain, makes certain decisions as a community, that we live and work in environments that also set us up for different behaviors and health. And then there's our general socioeconomic, cultural, and environmental factors that contribute to determine who we are and how we live, right? So you don't get to choose much in terms of who you are. You are the result of this environment that determines to a great extent the options that you have available and therefore the choices that you make every day. Now, what this results in part is in an environment that is filled with violence, with pollution of different kinds, with poverty, with alienation at the big picture. But at the individual person level, it is associated with loneliness, which turns out to be a bigger risk factor for health outcomes than obesity, even though we seem to be focused very much on obesity. But loneliness is a terrible thing. And chronic stress. Chronic stress that creates in our bodies the feeling that we are about to be eaten alive by a saber-toothed tiger that is not there and is not going to leave. And that saber-toothed tiger is the situation of walking around the corner and potentially being mugged. It's the situation of going to work and being fired. It's the situation of not being able to know if you're going to be able to have enough money for the end of the week for food. Or whether your son, who's not arriving to your home tonight, got shot in the corner or is dealing with drugs in the other corner. It's that constant worry that drives your hormones up. I'm an endocrinologist, so every problem, societal problem, otherwise it would be a hormones problem. If your hormones are driven up, and those hormones are going to drive your blood pressure and your sugars up, and then create the epidemic of chronic disease, of multiple chronic diseases that is affecting our societies and challenging our healthcare system. Now, of course, we can try to fix that problem by improving our healthcare system. But it seems to me that there's an enormous context here that we should be working on as well. This is the result of this society we're building. This is data from Scotland, but similar data was recently produced in Olmsted County, which is where Mayo Clinic is in Rochester, Minnesota. It looks very much like this. And this is a map that shows the proportion of people at different ages is in the bottom, proportion of people at different ages that live with one or more chronic conditions. And there are a few things here to see. First is, of course, the older you get, the more likely it is that you live with multiple chronic conditions, but you knew that. But watch this. If you look at the middle age group, right, between 40 and 65, if you look at the middle age group, the average person is no longer a healthy person. The average middle-aged person lives with one chronic condition. Right? And you can see that about 1 in 4 lives with 2 or more chronic conditions. And this looks like a wave, doesn't it? And it's moving from right to left. So when you hear that the aging of the population is a big threat, most of us think, oh, there'll be a lot of 90-year-old people to take care of. But there's another way we should think about the aging of the population, and that is that people are going to look like old people at a younger age. They're going to have multiple chronic conditions at a younger age. And my colleagues in pediatrics tell me that now chronic conditions in pediatrics is a fairly substantial problem. So this is moving in this direction. And so if we're setting up healthcare systems, let alone societies, that have to deal with what the future is going to bring, our fundamental concern should be how we handle people that are likely to be, like Maria Luisa, overwhelmed by a significant number of chronic conditions and the way we respond to them. Now let me make a strategic pause here, make sure that, can you hear me okay? Am I going too fast, too slow, just right? Does anybody need to get out for coffee? Are we all good? Looks like we're good. Now, what are the implications of this multimorbidity or multiple chronic conditions problem? This is one of the implications. Our labels actually don't work very well anymore. So if I tell you, I have a patient with type 2 diabetes, you almost immediately have to assume that the patient may also have depression, because 18% of them will have depression, or 61% will have high blood pressure, or 23% will have pain. So just saying type 2 diabetes and thinking, oh, high blood sugars is not enough, because that patient doesn't exist for the most part. The patients now exist combining multiple conditions. So if you have a program for people with diabetes, seems rather arbitrary, right? Why don't we have a program for pain, right? And so our labels and our buildings, our departments, the way we organize healthcare, by organs or by specialty, feels like it's for another time. It's not set up to deal with the problem of people coming in now with multiple chronic conditions. Or we need to have those people working like a team. We need to have them working together much more effectively than they've been able or been interested in working together up to now. But something fundamentally has to change. And why is that? Because patients that have other chronic conditions have a fundamentally different clinical problem in terms of how doctors will manage those patients. So here's a graph that shows 3 different ways in which other conditions affect the treatment of the index condition. One is by affecting the baseline risk for bad things happening. So say a patient with diabetes is at risk of having a heart attack. But if that patient also has high blood pressure, that risk goes further up. If that patient also has high cholesterol, that risk goes further up even. So the combination of different diseases can make your risk of a bad outcome go up significantly. Another way in which having multiple chronic conditions affects the care of these patients is by the way they respond to treatment. So take a patient with depression and diabetes. If you treat only the diabetes, you get this far. If you treat only the depression, you get this far. You've got to treat both of them together to have the full response for treatment. So you have to be able to manage both conditions at the same time. Another way is vulnerability. So say a patient with diabetes has bad nerve problems. They can't feel their feet, so they're very unsteady on their feet. They have pain at night, so they take a medicine, an anticonvulsant, has main side effect is dizziness, to try to deal with the pain. And they're trying to get those blood pressure metrics down where the quality metric is. And because they just, they start taking those medicines, every time they stand up, they get dizzy. The combination of 3 means this patient is now particularly vulnerable to falls. But this only occurs because these conditions are not coming together. And either the conditions or our treatments or both are affecting people's risk, responsiveness, and vulnerability. So it's very, very important that they have multiple chronic conditions. And if we follow our guidelines, which then, of course, create the quality parameters that we like to see implemented, our guidelines are also disease by disease. And they can't really account for all the possible combinations of diseases. But the problem is when we try to implement them all in people that have multiple chronic conditions, we run into risks like this, where the drugs that are recommended for condition A and condition B may interact and create a dangerous situation. Requiring people at the forefront to be particularly flexible in the application of these guidelines. Flexibility that sometimes is taken away, often by misunderstanding of what the quality parameters are. In this case, the quality parameter should be flexibility rather than adherence to the quality metric, which is very, very hard sometimes to implement. So, which brings us back to Maria Luisa. Because as somebody astutely points out, we might say, well, let's just use evidence-based medicine to help Maria Luisa. What does the evidence tell us will help Maria Luisa? So we'll find a randomized trial that justifies that particular tablet. You know, that's pretty good. In fact, his doctor probably just identified that to be the case. But, you know, there's actually a randomized trial that justifies that one and that one and that one and that one and that one. And just for fun, there's probably an observational study that justifies staying away or going for particular kinds of foods, you know, coffee good for you, coffee bad for you, sort of situation. Right? So clearly, we cannot really make the evidence care for the patient. Right? The evidence doesn't care for the patient. Our job is to make the evidence work towards our ability to care for the patient, but the evidence alone will not care for the patient. And so what happens is when we basically take the evidence and create these evidence-based guidelines and create our care pathways and create our quality measures and develop high-quality specialist care. I come from Mayo Clinic. It's a mecca of high-quality specialist care. It usually is very disease-focused, and as a result, it's context-blind. So for the patient that lives with multiple chronic conditions at the same time, the effect is that they will have complex regimens, increasingly complex regimens. They will, and we will deliver those complex regimens in an environment in which prioritization of care is actually very limited. We do a lot of care coordination, but my sense when I go visit, say, primary care medical homes and other instances of this, when I talk to care coordination, most of the nurses that are working on care coordination, their job is to make sure that the patients are engaged, which is code for saying the patients must be doing what we ask them to do. Right? And it's very rare that a care coordination will say, you know, that bisphosphonate you were taking for osteoporosis, we're going to stop it now. I mean, we don't stop stuff. You know, the prioritization usually is you put them in a list and the bottom stuff goes away. Nothing goes away. Nothing goes away, despite many patients finishing our visits by saying, doctor, can I stop this medicine? Can I stop any medicine? Any take one? Can I stop any? And then as a result, we have patients that, again, another astute observer in the room said, will become overwhelmed and look overwhelmed. So what is this work of being a patient that I'm talking about? Well, here's an approach. When we started this investigation, one of the things that was remarkable is how little there is in the literature about the work of being a patient. There is no chapter in the medical books. There's very little original work on the work of being a patient. So, which basically means we don't really know about it, we just haven't cared about it. And this is work from our colleagues, sociology colleagues in the UK. And using a model of work, they've identified at least these 4 areas. So a simplified first approach. First is the work of making sense of the work. This is why the patients might Google stuff up. They might read the package insert of the medicines before they start taking them. And then we get angry at them for doing their job. There's the organizing the work and enrolling others. Now look at that picture. So that guy, it's Sunday afternoon, the guy in the light blue shirt is watching the game, minding his own business, enjoying his beer. And then his wife, as every Sunday, will call him down and say, Lucas, it's time to set up the pillbox. And he's like, oh, I don't want to do it. Oh, come down here, let's do it now, right? And so there they are, and they're setting out the pillbox. You know if she's not calling him down, he's going to take the pills from the orange containers, right? You know that's going to happen. So she makes sure that he does it. Now, if you look at her left wrist, she has a medical alert bracelet. She's a patient too. And this is a common situation now for our caregivers, that they also live with multiple chronic conditions. So if she were to get sick, she were to go to the hospital, Lucas is not going to set up the pillbox, right? And so he's just going to take the pills from the little orange containers, and you know what's going to happen. He's not going to take them all, right? So the organizing work bit, the idea that adherence to therapies is social. It's a teamwork. It requires a village. It's important to recognize. But Lucas does not look sick. So his ability to keep people enrolled in his care, get help from others, is limited to his social skills. He needs to be loved. And he just looks lazy. He doesn't look sick. Right? And so it's hard for people with chronic disease to attract the kind of ongoing support that they need because they just don't look like they need the help. Then, of course, doing the work, going to the visits, taking the pills, taking the tests, and then the ability to reflect, is this work still worth it? Because they now have to do it again tomorrow. Now we now begin to think about, if we're going to engage patients and we want patients to be participating in their work, we need to understand the work that they are doing and support each of these steps if we want the results to be favorable. But that's not the whole story. There's more, because we are very excited about giving work to patients, right? Because it's empowering and it's great for patients, particularly if they're sick. We need to give them more work, right? And so we can ask them to prepare for the consultation, to watch this beautiful educational video we just put on YouTube, and we ask them to bring questions and be ready to ask new ones on the spot. We might want them to record the visit because they have a lot of time afterwards to listen to it and review it. We now have access to the medical record. So read our jargon. I know it's dictated, so some of the words don't make any sense, but you might want to read it. We won't change the language we use because it helps communicate with each other, so you may need to dictionary or learn how we speak. But it's for you. It's for you. We want you to communicate via the portal. Yes, you have email and Instagram and Facebook. We also have the portal. Yes, it's gray and it's not attractive, but it gets you a doctor. You need to self-measure, self-monitor, self-manage. We want you to manage your appointments, your prescriptions, your bills, this is not a bills. Keep your family and important others informed. We want you to take care of significant others because that's your responsibility. We need to advocate for others, advocate for yourself. Americans are saying in surveys that they're overwhelmed by how much healthcare is asking of them. So 40% of people over the age of 65 are endorsing this statement. Clinicians, healthcare, is asking for too much. The work is too hard, and it often gets delayed or doesn't get done. People are overwhelmed. And people are most likely to endorse this are low socioeconomic, so they have fewer resources to deal with it, are sicker, and they have someone to dump the work on. Those silent caregivers. So what we do for people that are overwhelmed is we label them, and we call them non-compliant. And non-compliance is a character flaw. You're a bad person if you're non-compliant. Any doctor that has reported to another doctor about a patient that starts by saying, I have a 65-year-old woman, she's non-compliant. That's it. I don't want to hear anything else about this patient. This patient is a nightmare. Nothing is going to happen. It's a dead end. It's a nightmare. Think about it. You're organizing your birthday party. Would you invite a non-compliant person to your birthday party? You probably wouldn't, right? Because they would show up without a gift. That would be terrible. So we need to change this. We need to change our language. We need to change our approach. So how we are going to turn this around? I think we're going to turn this around by focusing not in understanding first the work of being a patient, but also that patients have a given capacity to get that work done. And if we are aware of that capacity, we might be able to work with the patient to right-size the amount of work to achieve their goals to what they can actually accomplish without overwhelming them and leaving some behind, some capacity, so they can pursue their life's hopes and dreams. Nobody wants to be a full-time patient. I have 3 boys. I asked them, what are you going to do when you grow up? None of them have ever said, I want to be a great patient. None. So what is the capacity to engage with all this work? It's purpose. It's having a source of joy in your life. There's a reason why I want to be alive and I want to be vital. And you have no idea how many patients, if you start asking in the consultation, what are the sources of joy in your life, will actually have none to report. None to report. Resilience, ability to bounce back after adversity. Literacy, of course, if you know better, you know where to make exceptions and change the way you do things. Bandwidth, your ability to focus and get stuff done even when you're worried. There's some interesting studies showing that when you're very worried, when something is missing, and you're very worried, that your ability to solve simple problems gets limited. It's almost like the computer is busy with another software, and you don't have the ability to focus on the present. So you start making stupid mistakes. Obviously, physical health, mental health issues will reduce your capacity, financial difficulties, social isolation and lack of social skills. There are actually substantial problems for this population, and they cannot get the help. Like Lucas, right? He cannot get the help that they need. And environmental challenges. If you live too far away, if the internet barely gets to where you are, if you cannot get access to stuff, you're going to be in trouble. So instead of calling Maria Luisa non-compliant, we may want to think of her as having an imbalance of workload and capacity. And that we can work with. because we can actually work to deal with this increased workload, which may come from life or may come from our treatment, and we might be able to deal with this reduced capacity if it comes from being sick, from the personal, from the financial, or from the functional, from the social, economical. So how might we do that? One initial approach we're just testing now, so this is in prototype stage, is to use this tool in the consultation. So this tool, the patient fills it up in the waiting room, and on the left, it asks for a number of areas in their life, and the patient marks if these areas are a source of satisfaction or a source of burden or both. Then they fill the right side with things that they do in healthcare, take my pills, come to my appointments, check my blood pressure at home, whatever, and then they mark, are they a source of help, are they a burden, or are they both? And then when they come to the visit, they ask the clinician asks the patient, what stands out from this that you filled in? So it doesn't go through this, it doesn't generate a score. I know some people will be very upset at that because they would like a 9, But remember, 9s don't work. You actually do something like this in the PHQ-2 or PHQ-9, where you actually ask some of these things to patients, but you never look at the answers in terms of what it means that they're sad all the time. They look at the score, and you progress from there. So you already ignore some of the statements that people do in exchange for a number. So we are walking out of the number so you can look at what people are saying to you. Okay, so that's what this is about. And the idea is that, that these are areas that maybe the clinician is comfortable dealing with, but maybe the areas at the top are things that the clinician is usually not engaged in, and maybe a social worker or another member of the team can participate in if they're becoming problem areas. But the idea here is, here's life, and here's healthcare, and you're trying to see how one will fit with the other. But right now, you're just doing healthcare, and you have really no idea about how people live. When doctors used to go to patients' houses and live in the same community, we have a sense. But now, the difference between most of our patients and most of our doctors is so much that we only get to imagine how the other one lives. And that is not a good guide on making decisions. And then, of course, clinicians can also look at this side. If something that you thought patients were doing is not listed, probably it's not happening. If somebody lists something mostly as a burden and not a help, either you need to reframe it or you need to stop. Another approach is to do shared decision making, and I'll go through this fairly quickly. But for instance, we start things very automatically on people, but there's an opportunity to engage them and to figure out in the discussion what is important for them. If you're asking the question, what's best for you and your family, you need to understand what you value. And so here is the statin choice decision aid. A 55-year-old man has this level of risk, and the way it works is we say, Mr. Jones, you're in a room with 100 people just like you. If we close the door, open 10 years later and count, we'll see 92 people that would, like you, that would not have had a heart attack in the next 10 years, and 8 people would have had a heart attack in that 10-year period. I do not know if you're one of the green ones or one of the orange ones. Now, if all of those 100 people were to take a cholesterol medicine, a statin, what will happen? We'll close the door, make sure that they take it for 10 years, open the door and count, and the 92 people that were not destined to have a heart attack would have taken their medicine, their cholesterol medicine, and no benefit. Right? And then you have 8 people that were destined to have a heart attack. 6 will get their heart attack despite taking the medicine regularly, and 2 will avoid the heart attack because they took the medicine. Now, Mr. Jones, are you interested in taking a statin? Right? And so you might say, oh, actually, let's do, if you were Mr. Jones, how many of you would want a statin given these circumstances? So now, all of, except I think one person over here, all of you have violated the current guidelines for cholesterol use, because if it's 7.5 risk or more, you should be on a statin. That's 8%, right? So it does look ridiculous, doesn't it? But it is what it is. And that might be one of the ways in which you might reduce the burden of treatment on some patients by making sure that the treatments are aligned with patients' informed preferences. We've done this for diabetes. So you're on metformin, your sugars are high. You try diet and exercise, sugars are still high. You're symptomatic, you need a new drug for your diabetes. Which drug should we start? Well, let's find out. You are the patient. What aspect of your next diabetes medication would you like to learn about next? Most of our patients are interested in their weight. And so they might find that there are 2 medicines here that are helping them lose weight, and they might be interested in those. Okay, so what aspect of those medicines would you like to learn about next? Well, how do you take them? Well, one of them is an injectable. Oh, if I'm going to lose weight, I'll inject my eyeballs, doctor. Go ahead. Oh, but there's a pill, so I can take the pill. So I'll take the pill. Oh, wonderful. Anything else you want to learn about it? How much will it cost? All right, let's take a look. That pill, according to this, will be $8 a day out of pocket cost. Whoa, whoa, whoa. I'm used to metformin 10 cents a day. What is this $8 a day business? Is this 80 times better? No, they just got 80 times greedier. Oh, okay. So maybe I should. Some people are completely comfortable with that. Other people are like, no, the eyeball one, no, that's $11. Well, weight neutral, a tablet, good, $7. Geez, maybe I can't afford weight loss or weight neutral, maybe a little weight gain, 1 tablet a day, 10 cents a day, that's my medicine. And so patients can even navigate with their clinician together in the office a complex decision like this one. And we just tested this also in the randomized trial for antidepressants, where primary care clinicians and patients can choose the antidepressant that best fits their need. Doctors are not playing dead during these consultations. They're actively engaged, but so is the patient. Our experience is that everything we knew about shared decision making is wrong. It's not just for young people. It is not just for specialty care. Clinicians don't hate it. It doesn't take a year for people to make decisions, and it's not like they require a lot of investment in training. We've also learned that it doesn't introduce additional disparities in care. In fact, those most vulnerable actually get the biggest boost from having more support. And the other thing that we have not shown, and nobody else has, even though people write these policy articles about it, is shared decision making does not reduce costs, does not improve outcomes, has not been shown to improve adherence, and does not reverse global warming. Talk about the globe. People said nobody will use this. That statin tool that I show you is being used about 10,000 times a month now, and you can see the distribution of use in the United States. I think you have some catch up to do. In addition to prioritizing and deprescribing, which might affect the treatment burden, there are other things to improve capacity of these patients: wellness coaching, self-management training, palliative care. You know, we reserve palliative care for people who are really in trouble, but these chronic patients can't sleep, are in pain, and we don't call our palliative care colleagues, either in primary care or specialty care, to assist us with them. Mental health, of course, always a problem. Physical and occupational therapy, another area of underutilization. You know, these people sometimes can only do a few things in the day because they can't walk very fast. You know, give them a cane, give them a walker. They start getting scared. You know, super speedy, right? It's dangerous, right? But so here's Maria Luisa. When her son went to work and she was on the second floor, that's where she stayed for the whole day. If he left and she was on the main floor, that's where she stayed for the whole day. So we were able to mobilize resources and give her one of these things, and she now can gain a little bit more mobility. She can do more stuff in the day just by having that possibility. And that involves mobilizing resources, mobilizing services that already may exist in your community. What about evidence that this actually works? So here's an indirect evidence, and we need to do more work on this. But my colleague Aaron Lepine looked at 25 years of randomized trials of prevention of readmissions to hospital and reanalyzed all the interventions based on this model of workload and capacity balance, and found that the interventions that worked on that balance, even though they may not have mentioned it that way, and this was done blinded to outcomes, were 30% more effective than interventions that failed to support the capacity of the patient or reduce the workload of being a patient. And it doesn't matter how much we do in the consultation, our systems have to support us. So our systems create a lot of work for our patients. And this is a wonderful picture. I wish I knew where I got it. This is from, it came out on Twitter. But this system obviously asks patients to wait in line too long, right? And so they just put their shoes there. You know, they want to stay in line. But the other thing is we need to pay attention to capacity. Our capacity is given not only by ourselves, but also by our villages, by our families, by our communities. We must work on making our community supportive, because these patients with chronic conditions, which eventually will be all of us, will need all that support and all the help that we can get. But we are not building societies that look after each other, built with solidarity and kinship. We're building societies of individuals, and that society kills patients with multiple chronic conditions. What about accountability? Well, we need to rethink a little bit of that, because if those quality measures that are context blind are not going to work for these patients, what will? And I think it might be helpful, for instance, to start looking at measuring the burden of treatment and the burden of illness, along with this balance of workload and capacity. And there are some promising measures that could be used today. Also, if that balance is used, is the capacity is used to access care, use care, and enact self-care, we need to have some measures of ease of use and continuity and satisfaction. Again, measures that we already have, but we are not necessarily deploying in this way. And then when we look at outcomes, yes, disease control might be helpful, but we also have to have a significant focus on physical and mental function and role function, on health. So we can go back to Maria Luisa, and eventually, if we work towards reducing the healthcare footprint on her life and give her more health and more support and reduce the workload of being a patient, we may be able to be in a better position to answer this question, what is best for me, what is best for my family, and be more confident that the answer will be, it is our minimally disruptive care that is the best for you and your family. This is Maria Luisa. To her left is her granddaughter. She spent a year with us in our research group, and so when she went to visit her grandma in Alaska, she realized she could use minimally disruptive medicine with her grandma. So some of the changes I've shown you were her inspiration. This is one of them. She figured that in the afternoon, the dialysis center had 2 nurses that spoke Spanish. So by having her do dialysis in the afternoon, her social circle expanded of people that she could speak to. By chance, it also gave her half mornings, the days that she was going on dialysis, where she would not be in the dialysis center or in the afternoon sleeping, but rather she can use. So she became more of a full-time person rather than a part-time person because of the scheduling of the dialysis. She also contacted a nutritionist in Peru with instructions about what diet she should be having, and asked her to provide some recipes that could be prepared in Alaska that will remind her of the taste of her homeland, and had somebody come in and cook for the week. And so it increased her pleasure by looking at what her food should be that would still be safe, that will remind her of Peru. And she started getting happier. She started crocheting for her granddaughters, and she went from this to celebrating her 83rd birthday with her family. We need to do this for patients like Maria Luisa. Thank you very much for your attention.